Hi there, my name is Emma Rhodes. I am a clinical neuropsychologist at the Frontotemporal Degeneration Center at the University of Pennsylvania. And I'm going to be talking to you a little bit today about my study for the Penn AI Tech Collaboratory, which is about the feasibility of using digital monitoring to detect autonomic markers of empathy loss in the behavioral variant of frontotemporal dementia. So for those of you who don't know, frontotemporal dementia is an early onset neurodegenerative disease that tends to start showing symptoms in late midlife, so between the ages of 40 and 65. There are three established clinical phenotypes or presentations of this disease, and the one that I am particularly interested in is the behavioral variant. So you'll see the behavioral variant in the green in this diagram to the right. This variant involves primarily changes in social conduct and behavior, including really disinhibited or impulsive behavior, prominent apathy, a lack of insight into these changes, and a loss of empathy or compassion for people that they used to care about. So social and emotional dysfunction in bvFTD is often the first symptom that comes online, and it's a really prominent deficit that does persist all the way through the course of the illness. And as I mentioned, this can show up in the form of inappropriate comments or behavior, really disinhibited or impulsive actions, and again, this really callous and unemotional treatment of people that they used to love and care about. So this loss of empathy is a hallmark feature of the behavioral variant of FTD. It's one of the diagnostic criteria, and it's linked to poor functioning for both patients and caregivers. It's driven by brain volume loss or cell death in a distributed network of brain regions, many of which are highlighted in this figure on the right. And there are currently no treatments and no known modifiable mechanisms of this in bvFTD. And part of the reason why our research on empathy loss in bvFTD is lacking is because this is a really difficult construct to measure. So when we ask people to assess their partners and patients on terms of their empathy skills, it can be really challenging to get an objective and reliable report. Recent research has highlighted some physiologic mechanisms, including things like autonomic arousal and interoceptive processing, as being really important and potentially modifiable mechanisms of empathy loss in bvFTD. And so that is what my project is focusing on. So just as a little bit of a primer for the autonomic nervous system, this is made up of two complementary subsystems, the sympathetic and parasympathetic nervous systems, and these operate together sort of in dynamic flux to help us respond to our environment. And so sympathetic system is typically thought of as coordinating energy mobilization in response to something from the environment. So this is commonly referred to as the fight or flight response. And so we see the pupils dilate to allow for more information to come in. We see an increase in heart rate and blood flow away from some of our more visceral internal organs and out to our muscles to prepare for action, either to run or fight or face some kind of a threat in our environment. The sympathetic nervous system is typically associated with the subjective experience of negative emotions. So when we are sad, when we are angry, when we're afraid, we see activation of the sympathetic nervous system. And the way that we measure this is typically through things like skin conductance, so the amount of sweat that's coming out of the pores in our skin, our pupil dilation, and also things like blood pressure. In contrast, the parasympathetic nervous system is really geared towards energy conservation. So the terms we teach in medical school to remember this are resting and digesting. So when we are asleep, when we are inactive, our body signals more of our blood flow to go towards our visceral or digestive organs. And this tends to be associated with more positive subjective experiences of emotion. So when we have feelings and we're able to regulate or respond to them, when we need to focus on something or even express our feelings, we tend to see higher levels of parasympathetic arousal. Now, importantly, this is also linked to social behavior, in particular, people being agreeable with each other and displaying signs of empathy and prosocial behavior. And the way that we measure the parasympathetic arousal is using heart rate-based measures. So we are assessing the amount of time between beats of the heart and then overlaying that on top of the respiration rate, which gives us our respiratory sinus arrhythmia, which is sort of the primary outcome variable of how we measure this system. So to give you a little bit more detail, there's some really lovely research out of UCSF, one of my collaborators, Dr. Virginia Sturm, who has looked at this in detail. And she has found that shifts in sympathetic and parasympathetic arousal in behavioral variant FTD are associated with some of the social and emotional features that we see in our patients. And so we see a diminished amount of sympathetic arousal, and this tends to be associated with an insensitivity or a blunting to negative emotions and stimuli. So people with bvFTD don't show appropriate levels of disgust, self-consciousness, or embarrassment in situations where they really should feel those things. And they don't tend to respond to aversive environmental cues like odors. So they have less of a overt reaction, and this seems to be driven by reduced sympathetic arousal. She has also shown that elevated parasympathetic arousal is associated with reduced empathic concern, less agreeableness, and less prosocial behavior, and again, more emotional blunting. So we're seeing on both sides of the coin that both the sympathetic and the parasympathetic systems can contribute to some of these social and emotional deficits in bvFTD. Now, Dr. Sturm has performed all of her research using hardwired EKG and skin conductance leads. And what that means is that the participant has to sit still in a chair. So they are hardwired to an EKG amplifier, which means that they are not free to kind of move as they normally would. And they're very aware of the fact that they're being measured and monitored. The other sort of drawback to this type of method is that it's very sensitive to motion effects. So if the person were to even gesticulate, move their hands as we normally would, it can interrupt the signal from this data. So this is challenging data to obtain. But thankfully, we have seen a stark rise in the number of wearable devices that have been developed and can be used to measure lots of different aspects of people's daily functioning. So digital smartwatch technology and wearables have been designed with all different types of sensors that are capable of measuring anything from a person's position in their city through GPS or acceleration, but also some of these autonomic variables that I'm particularly interested in. And these have the benefit of being passive, meaning that they don't require any engagement from the patient or participant for them to work. They're unobtrusive, meaning that the person can really go about their normal life and not even notice that they're being monitored. And continuous, meaning that we can measure people for longer periods of time. These devices also happen to be unconstrained by wires and machinery, which make them very nice and portable. And they're adaptable for task-based assessment. So we can use them both in the clinic, but also at home in the patient's normal environment. My study will be using a device called the Empatica E4. This is a medical grade wristband that is specifically designed to capture some of the autonomic signals that I described earlier. So in addition to collecting data from a 3-axis accelerometer to get motion information, it also collects PPG and electrodermal activity, which are used to derive our primary outcome variables for the sympathetic and parasympathetic nervous systems. So for my task, because we're interested in empathy, we wanted to assess the patient's empathy in multiple ways. And so this is a task that is novel and it's naturalistic, meaning that it's designed to mimic a real world scenario. So in this task, a participant is being monitored by the watch, and the experimenter reads a script much like the one that you see on the screen. And this involves accidentally the experimenter pretending to accidentally knock a key behind a cabinet that's out of reach. So they say, thank you, sit tight before we remove some sensors. I just need to check something on this computer really quickly. And then they knock a key off of a table and then start to berate themselves a little bit. So they say, oh, shoot, I just dropped the key to the filing cabinet. I need that today. Oh no, this is so bad. I don't see it. Oh gosh, I can't believe I did this again. This is the third time I've done this today. I'm such an idiot. So the person goes on, the task lasts only 90 seconds, which is adequate amount of time for people to demonstrate some kind of response to this scenario. And so what Dr. Storm has noticed when she has used this task with her patients is that bvFTD patients tend to react with disengagement. So they tend to start looking at their phone or express some impatience that this is taking too long, whereas healthy controls and people with other conditions will actually attempt to console or help the person. So offering to use their phone's flashlight to help them find the key under the cabinet, or saying, oh no, I'm sure it'll be okay. So what we do is we video and audio record our participants engaging in this task, and then we code their behavior using an established coding system to sort of characterize how they responded to this situation. And based on prior research, we know that people with bvFTD will show measurable empathy deficits on this task. We also use a computerized task called the multifaceted empathy test. And for this task, a participant views 40 images that depict people in sort of emotionally charged situations with clear emotional expression. And they are asked first to identify what feeling the person is experiencing, so we can tell whether they can accurately recognize the emotion. And then also how much do they feel for the person or feel what they feel. And we know also that people with bvFTD have a hard time performing this task as well. Patients will be recruited from the FTD Center, where I'm faculty. We also have a nice collaboration with the Alzheimer's Disease Research Center. And so we will additionally recruit healthy controls who are around the same age to undergo the same tasks to use as a comparison group. So all participants are going to undergo the empathy testing with the smartwatch, but they also get a number of other measures and cognitive testing, MRIs, blood work, and things like that as part of our sort of center-wide research studies. So the overarching goal for this study is really to see if we can use the wristband to capture autonomic markers of empathy loss in bvFTD. So first, we're really interested to see if a person is asked to sit tight for 2 minutes and really let their mind wander, and we record their autonomic data during that resting baseline. Is that condition alone enough to get an association with empathy measures in bvFTD? Or the second aim would be then to look at more at the dynamic data. So looking at the recordings from the wristwatch during, or the wristband during the behavioral empathy testing. And so looking specifically to see when sad or angry images come up on the multifaceted empathy test, are they showing a sort of reduced level of arousal? And when they respond to the experimenter in the helping task, are they showing altered levels of parasympathetic activity that may drive their reduced prosocial behavior? So those are the primary aims of the study. We are currently gearing up for data collection, and I would just like to highlight a few AI tech collaboratory resources that are making this research possible. The first is the Penn Nursing Home Care Suite, and this is where we perform all of our behavioral testing. So this is a specialized facility that includes audio and visual recording that allows us to synchronize our digital measurement with the participants' behavior in the room. We also have a collaboration with the Penn Institute for Biomedical Informatics, who will be providing collaboration and consultation for some advanced statistical modeling. So the data that we get from the wearables is really high density, and so it requires special machine learning models in order to analyze it in a reliable and reproducible way. We're also collaborating with the Center for Neuroscience and Society, where we can take our findings from this study and really integrate them into the existing literature with a nice framework for, well, what does this mean for people living with this disease? What does it mean from an ethical standpoint and from a legal standpoint? And then finally, the Focus on Health and Leadership for Women group provides mentoring, networking, and peer support for women in academic medicine. And I am thrilled to be one of the AI Tech Pilot Study awardees. And thank you for your time.